Good morning, everybody, and welcome to this session. I'd like to thank the BPS and to the sponsors for supporting this excellent meeting. I'm James Deere. I'm a clinical pharmacologist from Edinburgh. And today we're going to have a very exciting session talking about the treatment of poisoning in low and middle income countries. So if I can pull up my first slide. Okay, so in this introduction, I'm only going to give about 2 or 3 minutes because I'm keen to get all the speakers on and have time for questions. We've come together funded by the NIHR, which for people who don't know is a UK government funder of healthcare research. And we've come together as a centre to tackle the challenge of poisoning in low and middle income countries, because that's where the main burden of morbidity and mortality is. So I'm briefly going to describe the centre, and then I'm delighted to have 5 real-world leading experts talk about particular poisons and particular challenges. So here's the centre. It's led by Professor Michael Edelston and Professor Indika from Sri Lanka. And we have partners globally from across the world. And the aim is stated there, to improve the diagnosis, very importantly, the treatment, and the knowledge of how to manage poisoning across low and middle income countries. And as you can see, we've got partners, and we've got partners today speaking from South Africa, from Bangladesh, from Norway, and the United Kingdom. I'm just briefly going to describe the work of the centre to give you a flavour of what we do. There are work packages, like many centres have, and the first work package is developing a new diagnostic test for methanol toxicity. And my colleague, Knut Erik, will be the next speaker who will talk specifically about the challenges of methanol. We have a work package around pesticides, and Michael Edelston, who many of you will know, will then give a talk around pesticides. But the other work packages are aimed at improving the care. So there's guideline work package working with the World Health Organization. And the work package that I lead is about developing research capacity in low and middle income countries so that people can do research and have a legacy of trained researchers. The final work package will be discussed more by Corinne Marks at the end, and that's the development of poison information centres. So the Global Research Academy is the work package I lead, and just finally to highlight this, what we're doing here is we're taking gifted young researchers from low and middle income countries and providing them support to do master's degrees or PhDs. But more than that, we're building a virtual academy where they can interact, support each other, and build the next generation of researchers. And we have members from across the globe, particularly Africa and Asia. But again, if anybody's interested in hearing more about this, please do approach me afterwards. So I'm going to stop there. I'm going to introduce my colleague, Dr. Knut Erik Hovda, who is from Oslo and is a world expert on methanol, and I'll be delighted to hear him speak.
Thank you so much, James. And for the sake of time, I think we're just going to start, so we might have time for a few questions afterwards as well. First of all, I have a short disclosure. I'm a CEO and co-owner of a small company called Orphan Diagnostics, and we're trying to make a methanol poisoning diagnostic tool available. It's not available as of yet. It's not a commercial product, but I still wanted to make it this short disclosure. So methanol poisoning is a global issue. So all the red dots you'll see here, this is from a web page by Médecins Sans Frontières, Doctors Without Borders. All the red dots here are not single cases. These are outbreaks, and they are typically handful, dozens, hundreds, or even more than 1,000 patients in each of these red dots. This is from the last 25 years, and we've found more than 1,000 outbreaks as of now. Unfortunately, this is very, very likely to only be the tip of the iceberg because the majority of these patients is never diagnosed. We never know what is happening. You might have read now the news for the last year after the Lao incident in November 2024, where there were 6 young people dying, and it's been all over the news, and it still is. Well, these are only 6 out of thousands of fatalities that really nobody looks at or cares about, but it's there and it's affecting all of us. So methanol itself is not toxic. It does not even make you drunk, but it's metabolized in the liver through formaldehyde to formic acid or formate, which is what is accumulating and giving the toxicity. Formaldehyde is also toxic, but the half-life is so short that it won't really affect us. The fact that this metabolism is ongoing and it takes time is also the reason why there is time until we get development of symptoms. Typically, you will not be sick from drinking methanol there and then, but you will be sick the following day or even later. So that as time goes by, more formate accumulates and you get more ill, and eventually many patients will die. And we have fatality rates passing 40, 50, 60, 70, 80% in some of the outbreaks. An interesting feature is that formic acid is more toxic than the anion formate. And why is that? Well, firstly, it passes blood-brain barrier more easily. It passes the cell membrane and the mitochondrial membrane, and it inhibits the mitochondria stronger as compared to formate. And even if this reaction here is almost all the way to the right, so there is more formate in the blood as compared to formic acid, the more acidotic we get, the more this reaction is pulled to the left. You'll have more formic acid and relatively more toxicity from methanol. The diagnostic part is a difficult part. So patient history and clinical features is what is available everywhere. And this is the most important task for us to sort of have a grip on. The patient history, especially the fact that if your patient has been drinking and developing symptoms the following day, or if there are other ones in the surroundings who has similar symptoms or visual disturbances, you should be aware of that. Clinical features are typically diffuse, and methanol is considered the big imitator, which is also probably the reason why the numbers we see of patients coming in is only the tip of the iceberg, because these patients get all kinds of diagnoses other than methanol. The most consistent clinical finding is hyperventilation, and you'll find that in most patients as long as they are acidotic. But this alone is not a specific sign for methanol. There are some analytical options as well. The arterial blood gas, which is of course available everywhere where we live, not available everywhere in the low and middle income countries. But it does help us a lot in regards to saying how the extent or the degree of the metabolic acidosis, but it will tell us nothing about the origin. The osmol and the anion gap are both very useful, but they're unspecific, and most of all, osmolality is unavailable in most parts of the world. Make a special note that many people and clinicians think they can use blood gas to measure the osmolality, but this cannot be used for any practical purposes at all as regards to toxic alcohols. Methanol analysis is considered the gold standard, but the problem is the availability, which is also why we have introduced the formate analysis as a diagnostic way of approaching the case, because you cannot have any symptoms without generating formates. And this brings us to our study and our little device. Our little device is detecting formate without the need of any laboratory at all. It's just a small plastic brick. It doesn't require any laboratory personnel. It does not even require electricity. And we can detect formate hours before the symptoms even start with the patients, within a few minutes bedside and a drop of blood. So the NIHR Right 4 trial is now, we're working on identifying patients in Bangladesh and India. And this is an ongoing trial. And what we're doing is trying to include everyone with a suspected methanol poisoning or a metabolic acidosis of unknown origin. And what we're doing is comparing this little device to a spectrophotometry method that we have introduced to all the hospitals participating. So the treatment is somewhat straightforward. In addition to the supportive treatment, these patients specifically need bicarbonate because of the mechanisms I mentioned, that formic acid is more toxic the more, or formate is more toxic the more acidotic you get. You want to treat the acidosis very, very early. The antidote, either you use ethanol or fomepizole, is there to block the metabolism of methanol. Folic or folinic acid is to support the endogenous metabolism of the formate acid already being produced, because we as humans are in lack of folate, and that is the only reason why methanol is toxic for us. Most animals which has enough folate will continue to metabolize formate, meaning methanol is never toxic to them. Finally, we have the dialysis, which will remove both methanol, formate, and correct the acidosis. So from our point of view, this methanol poisoning chain of life is what we need to change the whole concept of why people are dying. We need awareness among public, among stakeholders, and among healthcare personnel. We need knowledge, and this picture here is from online training we have made with Doctors Without Borders, which is available for free, and it can be used on laptops or on smartphones. And it's a quite big training program. It takes about 4 hours before you have your badge, but it's for free, and it's available for everyone. We need to have simple diagnostics available, and preferably bedside. That will enable us to know who to treat. And treatment is there and it's effective. The problem is, and this is what I've called the methanol paradox, the extremely good treatment we have is not where the patients are. So in order to try to combat that, we have, together with WHO and Doctors Without Borders, tried to make what we call the Fomepizole Access Campaign, because Fomepizole is a very effective antidote, but it's expensive. However, Fomepizole has been off patent for more than 15 years. So the minute we can get the volume up, the price will go down, and this will simplify the treatment big time globally. Finally, we need emergency preparedness plans, because we cannot prepare whether we are in Belfast or in the UK or in Oslo. We cannot prepare the same manner as you would have to do if you're in Dhaka or in Phnom Penh in Cambodia. Conditions are different, and you need to plan ahead before this starts. You need to know what are the capacities in the various hospitals. How do I treat them? Where do I send them? Where is their ICU capacity, dialysis capacity? How do I send them? Do I send them in an ambulance, a taxi? Do I send them on a tuk-tuk or back on the back of a donkey? I need to plan this up front. So is this a lost opportunity, or is this a potential for improvement? Well, methanol poisonings are deadly, but treatment can be very, very effective. Diagnosis is and will be the most difficult part, but if we understand the basic principle, it makes it all much easier to treat them from a use what you have perspective. So the testing of a new diagnostic device is ongoing, and NIHR Right 4 is currently including patients in Bangladesh and India, and the last handful just came in today. Thank you so much for your kind attention.
Thank you very much. That was a wonderful talk. So please, we'd like to have some questions. If you've got any questions, please come to the front, because I can't really see you. Please come to the microphone at the front.
Thank you very much for this very interesting topic and interesting talk. This problem of methanol poisoning, it's also, as you say, it's worldwide, and in several countries in the Middle East, including Syria, we have several cases of methanol poisoning. So I have two questions, actually. The first one, during the war in Syria, there was no fomepizole. So they were not able to treat with fomepizole. Ethanol alone, is it enough to treat? Because it is just compete on the metabolism. So it is just delaying, not like antagonist, exactly like fomepizole. And the thing is about diagnostic, usually maybe patient came to hospital when they start losing their sight. Is it effective to treat at this point? And the new diagnostic, early diagnostic, will be helpful at that point? So because they already will have some symptom in the eye, so that they go to hospital.
Thank you so much. These are very good questions. I'll take the last one first. And the simple answer is yes. It will be still effective to treat them. And if we go back about actually more than 100 years, when they had some big outbreaks of methanol, they were not aware of the mechanisms and how to block it, because that only came around 1945, 1950. But they saw that these patients had a very severe metabolic acidosis, so they gave them massive amounts of bicarbonate. And the result was that they actually got their vision back. But it only lasted for a few hours, because then they swapped and turned around the toxicity of the formate that was already being produced. But they did continuously metabolize more, and so eventually they lost their vision and died again. So in that context, many of your patients, not all, but many of them would, even after a couple of days, would be able to treat them and they would get their vision back. Most of all, you'll be able to save their lives. Second, as regards ethanol and fomepizole, ethanol is very effective. We have done 2 trials on this, one in Norway and one which was in Czech Republic. And what we found that the number of survivors is not significantly higher when it comes to fomepizole as compared to ethanol. But these are in context where you're able to measure the ethanol level in the blood when treating your patients. This is a difficulty because all of us in this room would metabolize ethanol differently, and it would change over time. So you will never get the ideal 100 per milligram per deciliter level of ethanol in the blood, but it will still be sufficient to treat the patient and save the patient in most cases. So yes, you're right, you're only temporarily treating the patients when using ethanol. But on the other hand, you're only temporarily treating them with fomepizole as well, because you're only binding to the same ADH enzyme. And methanol will be left in the blood, either until you are breathing it out, mostly, partly also through the urine, but more than 80% through breath, or you have to dialyze them to get rid of the alcohol which is already there. But the antidote per se is effective. And as long as fomepizole is unavailable, you can use ethanol, and you can use whatever ethanol is available. Beer, wine, liquor, you can use intravenous or oral ethanol, you can use medical grade alcohol or non-medical grade, doesn't matter. The volume should just be adjusted to the concentration itself. Pardon me? Folic acid can be used, folic or folinic acid, and it will not be able to supplement, well, it will supplement, but you cannot use it instead of the antidote, because there are only, there are only theoretical and animal studies showing the effect of this. And it will never be done randomized control trials for folic or folinic acid. And the reason for that is because then you have to poison a lot of patients, right? Then you have to avoid giving them any treatment and then randomizing and see who's going to survive. So it's from an ethical point of view never going to happen. But it's from a theoretical point of view, it's a good addition to the other treatment. And it's cheap and there is no side effect, of course.
Fantastic. Please go ahead. But we've got time for 2 more questions.
Okay. I'm Zacchaeus from Nigeria. Thanks for that beautiful presentation. Recently, I watched a documentary of car battery poisoning in Nigeria, affecting a particular community in Nigeria. I want to ask, your research group, are you interested in coming to sub-Saharan Africa and Nigeria, particularly having the largest population in the area? Because there's a lot of acute poisoning in Nigeria. That's my question. Thank you.
Thank you so much. I would love to introduce this or go ahead with the same trial in Nigeria. The only thing is we would need the funding, because every single patient we are including to the trial, we're giving fomepizole. And we will we're looking into to apply for more funding to expand this trial to bigger randomized control trial as well. And the reason why we're only doing Bangladesh and India now is that is the limitations for what we've already applied for in the protocol and the funding we have available. But as of from 2026, our little methanol poisoning initiative with Doctors Without Borders is actually moving the main site from Hong Kong to West Africa, to the Ivory Coast. And with that, we'll also put more focus and attention to methanol poisonings in Africa. So it would be very, very interesting to put it up, a similar trial in Nigeria as well.
Fantastic. And just to add that we have members of the centre from Nigeria already involved. Please, last question.
Thank you. Very interesting presentation, a long, long time, and it's amazing as doctors will remember cases. I vividly remember 1985 and a French polisher who took an overdose. He took a large volume, and my question really is, can you treat deliberate overdoses rather than these random ones where people seem to get poisoned by beer that's been tampered with? Is there a difference?
Thank you, that's a good question. I think a few of the last ones we had in Norway, because this is kind of infrequent. We had some big outbreaks, but a few of the last ones has been deliberate poisonings. Some of them would get hold of more pure methanol rather than the mixed one that you will find in most. I mean, most poison patient will be affected by methanol being mixed into regular alcohol to make more profit, right? Because I didn't mention this, but methanol is, in addition to be used industrially, it's now being used increasingly much as a fuel because it's an environmentally friendly fuel. And the big shipping industry internationally are now saying that you either have to build your new ships based on running on ammonia or methanol. So the volume is really, really high. That means that they will be getting hold of a lot of volumes, mixing it into alcohol, where we see most of the patient. We still see some of the patients actually drinking pure methanol as well, but it's more uncommon. The treatment concept will be the same. The symptoms will still not start until 12 to 24 hours later, but they would typically have a more severe start of their symptoms because the alcohol, it's not like an on or off switch, right? It will gradually start the metabolism if there is a mixture in there. So they would typically have a more gradual onset of symptoms, whereas if you drink pure methanol on purpose, you'll have more abrupt symptoms coming. The treatment would still being the same, and we had some very, very severe poisonings coming into our hospital, and 2 or 3 days later, they'd be walking out of the hospital without a single sequelae based on that same treatment. So it's super effective, given you know who is poisoned and you can start the treatment.
Fantastic. Thank you very much for a wonderful talk.
Thank you.
Next, we have Professor Michael Edelsten, who is Professor of Clinical Toxicology in Edinburgh and a true world leader on pesticides. So, Michael, we look forward to hearing about pesticide poisoning.
Hi, good morning. Thank you for coming to hear our session. I'm going to focus on organophosphorus poisoning. This is about the clinical pharmacology of pesticides. There's hundreds and hundreds of pesticides out there, but the one toxin that's killed more people than pretty much anything else in the world is organophosphorus insecticides. That's responsible for millions and millions of deaths across the world once they're introduced into the agricultural practice in the Green Revolution. So here's the kind of typical patient we'd see in Sri Lanka, for example. We think it's about 150,000 deaths a year in physically well people beforehand. This is the acetylcholine being released from cholinergic synapses, binding to the acetylcholine receptor, and then coming off and being broken down by acetylcholinesterase. When you take out acetylcholinesterase, as happens with nerve agents and with pesticides, you then get overstimulation of all the nicotinic and muscarinic receptors across the body. You can summarize the patients. So they lose consciousness, they breathing difficulty, so the neuromuscular junction fails, the lungs become full of fluid, the heart rate becomes slow, the blood pressure falls, they defecate, urinate, they're covered with sweat. So they're a very characteristic group of patients you see coming into the hospital. So here's a patient who has got the muscarinic features. His lungs are filled with fluid, and it's so full of fluid it's now pouring out of his mouth. The next slide shows the nicotinic features. So this is a man who's actually taken a carbamate. And I think you should start seeing, they promised me this would work. It doesn't. What this is supposed to show you is fasciculations. If you can imagine, this man is deeply unconscious with a GCS of 3. His muscles are now twitching madly, and whole motor units are being stimulated with the overstimulation of the nicotinic receptors. What you saw before with the fluid was muscarinic receptors being stimulated. As a result of that fluid in the lung, the neuromuscular junction not working, the overstimulation of the neuromuscular junction and downregulation, and actually the preeminent cause of respiratory failure in humans is a lack of central respiratory drive, where the brainstem stops telling the body to breathe. And we have patients like this being ventilated in the medical wards, then hopefully in intensive care. And in this graph shows you over 2 years, 42% of all patients And all patient days in this intensive care was taken up with patients with pesticide poisoning. So in certain parts of the world, this is a phenomenally important question. Unfortunately, our management is still very retro. We're based on 2 papers from 1955, one from the New England Journal of Medicine saying that atropine is the anticholinergic, the antimuscarinic we should be using, and then a paper from Wilson's group describing the development of oximes and praladoxime. And so these are the 2 treatments we use for these patients. Let's go through the antidotes, how they work, and the trials that have been done. So this is the patient you'll typically see coming in unconscious, pinpoint pupils, covered with sweat, often defecating, urinating, and fluid pouring out of their mouth. So this is the time we're trying to work out the muscarinic features, how to treat them. Cynthia Aaron, about 1998, published a chapter in this toxicology book. And she argued we don't know how much each person needs, so we need to start small and build up fast. Most of the guidelines were things like give 5 milligrams every 15 minutes. She argued we can look at the patient and then double dose. She said give the patient whatever you can give, 1 to 3 milligrams of atropine, and watch for 5 minutes. Because we know from the anesthetic literature, it doesn't take longer than 5 minutes for the atropine to have its full effect. And we're looking to improve the blood pressure, the heart rate, and get rid of this fluid out of the lungs. So she says at 5 minutes, if we don't get an effect, we then double the dose and continue to double until the patient responds. So we might give 2 milligrams, wait 5 minutes, and then 4 milligrams, wait 5 minutes, then give 8 milligrams. So once we've given it, we're drawing up the next doses. And always looking at the patient and trying to titrate it to the patient in front of us. So we took this guideline, published it, and our colleague in Bangladesh, Professor Abul Faiz, in the hospital in Chittagong, tested that. Now their conventional regimen here was 5 milligrams of atropine every 15 minutes. And what they compared it was with this titrated doubling protocol. And what I hope you can see here is the time to resuscitation, which we call atropinization, when we've got enough atropine in the body to counter the effects of that overstimulation. Took 2.5 hours with the normal procedure down to 24 minutes with the titrated protocol. So patients were much more rapidly stabilized. And the case fatality fell from 22% down to 8%. If we look at the timing of that fall, it's in the first few hours when they arrive in hospital. As you resuscitate them properly, you can prevent that death occurring. So this was really clear evidence that rapid atropinization was beneficial. And this is the one message to come away from this talk. What works in organophosphorus poisoning is atropine, ideally in a titrated method. The study we're trying to do now in the NIHR is how early we can give it to them. Can we give it in the village? And our idea was, like the soldiers who have auto-injectors in their pocket, could we have it in the village? So when someone became ill, a non-trained person could grab it, inject the person, and they would therefore have treatment for that first few hours as they got traveled to hospital. Unfortunately, we found that didn't work because people were worried that if they did inject someone, they'll be blamed if that person went on to die. So we're now trying to work with ambulance services to see if they can bring it with them and apply it when they first arrive in the village. But this is the fundamental treatment of organophosphorus poisoning. But what atropine does is turn off the tap. It doesn't empty the bucket. If we think of the lungs as being full of fluid because of this overstimulation, giving atropine is really powerful because it turns off that production. But it doesn't help you empty it. So instead we have these 2 pumps here, the ENaC pump and the sodium-potassium ETPase, and that takes sodium out of the lung and water should follow. So instead of water flowing out the top of the mouth, hopefully it'll be reabsorbed. And how might that work? Well, salbutamol stimulates both of those. The safest and easiest way to give salbutamol is through a nebulizer rather than intravenously, though of course the amount of fluid in the lung will reduce its ability to get to those receptors. But we asked ourselves, could we give nebulized salbutamol and atropine to both turn off the tap and empty the bucket? And this study was carried out by Rabi here in the audience about 10, 12 years ago as a small dose feasibility study or a pilot study comparing 2.5 milligrams of salbutamol with 5 milligrams of salbutamol versus saline placebo in addition to the standard of care, atropine and oxygen. In the northeast town of Sylhet, just 25 patients in each arm, and we're trying to get oxygen saturations back to where they should be. So here's the graph of the 3 different arms, and what you can see at the beginning, despite having having oxygen treatment and atropine, they're hypoxic. Over the next 20 minutes, the effect of the atropine and oxygen works, and by that time, they're up to about 95%. If we look at the effect of atropine, of salbutamol, you can see here in red, there's no effect of salbutamol compared to no salbutamol, but the 5 milligram salbutamol was probably worse. So unfortunately, this approach of trying to speed up even further the clearing of the lungs didn't work. Pralidoxime is the key antidote that was developed in 1955. This works by ripping off the organophosphorus compound that's deep in the cleft. Here's the cleft of the acetylcholinesterase, the OP in the base, bound by this hydroxyl group here. And what oxime does is pull that out. This is the reaction here. It gets inhibited acetylcholinesterase, and then you get the acetylcholinesterase very slowly reactivating. Oximes come and speed that process up. And the WHO in 2000 said we should be using oximes in all patients. But actually the data for that is quite weak. And actually, if we look at the different types of organophosphorus compounds, there's mostly 2 types. Here you can see diethyl groups, and here there's dimethyl groups. And how the acetylcholinesterase responds to oximes is determined by whether they're dimethyl or diethyl. That's shown here in this graph. So here is a patient who's quite sick on arrival. The acetylcholinesterase is completely inhibited and then gets reactivated by giving pralidoxime. Here's a patient with a dimethyl organophosphate, which is less severely inhibited, but there's a very poor response to the pralidoxime, and that's typical for dimethyl organophosphates. And S-alkyls here, severely inhibited on admission and no response at all to pralidoxime. So somewhere between 30 and 50% of all patients will not respond to pralidoxime. So you have to hope it's safe. We did a randomized controlled trial, which is included here in this meta-analysis. And what you can find, if this is the line of no effect, the overall conclusion that pralidoxime is harmful, both in terms of mortality and in terms of respiratory arrests. So this oxime, even though we've been using it for many years, probably doesn't benefit patients. So the last one we're doing at the moment, or we've just finished, is calcium channel blockade. This came out of a paper that came out of Iran in the early 90s, early 2000s, argued that magnesium sulfate was useful for organophosphorus insecticides. If we think in terms of neurophysiology, if we can block the calcium channels presynaptically, we can reduce the acetylcholine release. Less around to stimulate, and therefore you need less atropine to counter the effect. There's been about 6 or 7 trials previously done, all small. This is the line of no effect, so everything looks like it should work. We did animal research, which showed an effect to reduce both the acetylcholine release and also the postsynaptic damage that occurred from overstimulation. So it looked like magnesium should work. With Rabi and colleagues in Bangladesh, we set up a randomized controlled trial in 10 hospitals, which covered around 100 million people. So they were being drained into these hospitals. We aimed to recruit 3,500 patients, but unfortunately at 1,700 the trial was stopped because neither magnesium or nimodipine in classic doses used for preeclampsia and for subarachnoid hemorrhage had any effect at all. So it was a great trial. It went on for about 3.5 years during COVID, but the results were not as hopeful as we wanted, not as good as we wanted. So the second message and the final slides here are about the Salisbury organophosphorus attacks. These 2 individuals were poisoned with Novichok. They were found on a bench, and the paramedics who found them thought they'd taken fentanyls. They had small pupils and they were unconscious, and therefore in the UK scenario, that's very likely to be an opioid. However, globally, these patients were actually organophosphorus poisoned. The characteristic size of time, both of them are sweaty, one of them are vomited, one of them are defecated. So there were clear features there of what I call the wet opioid syndrome. And in future, if we have more attacks like this, it's going to be really important that doctors across the UK recognize these features and understand they're not opioid. And also, this is an example where food got contaminated by organophosphorus compounds in the 1970s in Jamaica. And because the flour that was contaminated was used to make dumplings in 3 different towns on 3 different occasions, patients arrived on 3 different days into hospitals. I think 40 patients in this hospital in one day, but the worst case was 25, 30 patients coming to this hospital with around 15 deaths. Out of the blue, suddenly, contaminated food. This could be intentional in the future, it could be unintentional, and those are going to be very difficult to recognize. Thank you very much.
Thank you very much, Michael. We've got time for a few questions. If anybody wants to, again, come down, please come down to the microphone. And once again, I'm blinded by the light and can't see you. Please.
Hello, my name is Rafael. Thank you for the talk. It was really interesting. I worked in a forensic toxicology lab in Brazil for a couple of years, and we had many pesticide cases, post-mortem cases, but most of them were carbamates, actually.
Aldicarb.
Yes, mostly. Normally homicide or suicide. Do you reckon that all of that, you focus on organophosphates, do you think everything would be applicable to cases of carbamate intoxication as well?
Most of the trials I do don't work. Nothing really benefits patients except atropine. So good clinical care, fantastic nursing care, oxygen, fluids, and atropine will work for carbamates and for organophosphorus compounds. Oximes are classically not used for carbamates because carbamates reactivate by themselves more quickly, but I don't think oximes work terribly well in organophosphorus compounds either. I would want to be in an HDU somewhere with just fantastic nursing care and atropine and oxygen, and that will work beautifully for carbamates. Many carbamates don't need reactivating, don't need activating, they're already active, and therefore their effects are very rapid. So the problem with that, people die before they get to hospital, more commonly than happens with organophosphorus compounds.
Thank you.
Please.
Hi. Can I just ask you about atropine? You compared the kind of doubling regime with the standard of care. Did I see correctly that the dose of atropine required was in over 100 milligrams?
So the mean was about 25 milligrams. Okay. So some patients will require 75 or 100, but if you're lying there unconscious, I can't guess whether it's 2 milligrams or 30 milligrams or 100 milligrams. So there are patients requiring grams a day. I'm not quite sure why.
Yeah, I wonder, do you think atropine is the best antimuscarinic agent to be using?
Well, the nice thing about atropine, it's both centrally acting and peripherally acting. So if we use things like, I can't remember its name now. There's another one classically, which is peripheral acting, which will not give you any central benefits. There's hyoscine, which gives you central benefits. So you can titrate those. The nice thing about atropine is it works both centrally and peripherally, and it seems to work very well. Could there be better? Yes, there possibly could be, but would it be available? And how would we dose it? So we have to do those studies.
Please.
I'm getting the impression from both these talks that if we think about this medically and maybe with diagnostics, these problems are solvable, whether it's methanol or in your case, organophosphates. And does that apply, does that really mean that our Novichok, which of course is meant to be the most powerful, can be beaten as long as we think about it?
So there's I think the big difference in methanol and organophosphorus is the time frame. With methanol, you die at 36 hours. So as long as you get that diagnosis right in the first 12 hours, for example, you've got a very, very good chance of saving that person's life. The problem with organophosphorus is sometimes they're very quick acting. So if you're dead at 15 minutes, it doesn't really matter where you are in the world. I mean, there's definite cases of parathion poisoning in Germany where the ambulance would arrive within 30 minutes with a doctor in the ambulance. They would intubate the patient, but the patient would die. So there's a lot of damage happening really quickly with organophosphates. So I don't think, I guess another difference between methanol and organophosphates is organophosphates is something you buy at a shop and use it in farming. It's much more rarely is it used like sarin nerve agents. So to me, and what I didn't think I had time today was go to the public health response, which is step out of clinical pharmacology and medicine and go into the government to simply ban the most toxic pesticides, which is what I think we can do. So I don't think medicine is the answer for organophosphorus compounds, but it can be the answer for methanol.
Yeah, one last question.
Yeah, I just get interested about the idea of like preventing the release of acetylcholine by like magnesium sulfate. Anyone think of Botox because it also inhibits the release of acetylcholine?
So no one's thought about that. We thought about magnesium and nimodipine because we can titrate it and we know how to use it, and it's used routinely in clinical care. So that was why we approached that, and we got no benefit at all. So I don't think I'd be moving to a braver botulinum approach of trying to alter that, because it's irreversible, the effects of botulinum, or at least for a time until you replace it. The nice thing about the magnesium is you can titrate it, turn it off, or turn it down. So no, that's too brave for me.
Thank you very much, Michael. So our next speaker, I'm absolutely delighted to have Dr. Rabi Chowdhury from Bangladesh Medical University come and talk to us about snakebite toxicity. So slightly different to the first two speakers, but certainly a major global challenge. Thank you, Rabi.
Thank you, James. Yeah, slightly different problem, but it's a substantial problem in low middle income countries, the snakebite is. I do not have any conflict of interest, and I have used some of the images of my patients, which I have their consent or assent. If we look over the global snakebite problem, it's one of the neglected tropical disease. Annually, around 5.5 million bite happens worldwide, and amongst them, about 2.7 million are venomous bite, and it causes nearly 130,000 deaths globally. So, except those deaths, a large number of patients also suffer from different sort of disabilities due to the extensive tissue damage. And many of them require amputations because of faulty primary preventive care. And roughly 95% of the venomous bite happened in low middle income countries. And if you look over the map, you can see that of them, 70% case actually happened in India, Bangladesh, Nepal, and Myanmar. So we are full of snakes, and a lot of venomous bite we handle every day. The scenario of snakebite in Bangladesh, we recently finished our national incidence study, and we found that around 400,000 bites happen in Bangladesh annually, and of them, probably 24% of them are venomous bite. And we do experience 7,500 deaths annually in Bangladesh, and also around 11% disability of different form, and also a considerable proportion of patients have suffered from post-traumatic stress disorders. The pharmacology of venom is mostly of 4 key pillars. The main problem is the neurotoxin, blocking the nicotinic acetylcholine receptor. Second important is the protein phospholipase, snake venom phospholipase, which has a role in neurotoxicity as well, but mostly do the cytotoxicity and myotoxicity, causing tissue and muscle damage. Third important component is metalloproteinase. Metalloproteinase is responsible for coagulopathy or hemotoxicity and also cause tissue damage. And there are a series of other proteins which contribute mostly to cytotoxicity and myotoxicity. Amongst the neurotoxin, there are 2 broad categories of neurotoxin. One is the depolarizing neurotoxin, mostly involving the presynaptic terminal. Those are the beta toxin, PLA2, or beta bungarotoxin. And it affects mostly on the terminal axons of the neuromuscular junction, extensively damage the axonal structures by increasing the calcium accumulation and overload, blocking the calcium channel, and it also causes complete disruption of the transmitters, that is the synaptic vesicles, and sees the neurotransmitter release. The second type of neurotoxin is the non-depolarizing toxin, that is the postsynaptic toxin, which we also call alpha toxin. That is the three-finger toxins from cobra and the alpha bungarotoxin from the crates. So the postsynaptic toxin per se have not specifically damaged the cell itself, but it competitively bind the nicotinic acetylcholine receptors. They mostly work extracellularly and the muscle end plate. So the difference of these non-depolarizing and depolarizing toxin is in the presynaptic toxins, that the beta toxin, they act very fast and they damage the axonal terminals. So you have to give anti-snake venom very fast to recover them from the neurotoxicity. But for the alpha toxin, since they do not damage the axonal terminals, so for most of the cobra bites and some sort of crate bites, the anti-snake venom delivery can be delayed. So Bangladesh is quite a good ground of different sort of snakes. We have two different variety of cobras, Naya Naya and Naya Kauthia. We have 5 different varieties of crates, deadly venomous. These are Bungarus carulus, the common crate, Bungarus fasciatus, black crates, and greater walls crate. And we also have deadly vipers like the Russell vipers and green pit vipers, and we also have some sea snake, that is the saw-scale vipers of different types. So for cobra and some sort of crates, the anti-snake venom effect can be delayed, but for some crates, you have to really give the anti-snake venom fast, otherwise the neuroparalysis cannot be reversed. And ultimately, those patients require ventilation. This causes progressive flaccid paralysis, and usually they are descending type of paralysis. Started with the ophthalmoplegia, then ptosis, ultimately involved the big muscle groups, and this is ptosis and typical broken neck signs. And the only treatment option we have is the anti-snake venom. We can also try neostigmine, since it is a competitive blocker of nicotinic receptor, and also glycopyrrolate been also tried in India without any added benefit. The second important component is the snake venom phospholipase A2, PLA2. This is also can be 2 different types, the enzymatic venom protein or the non-enzymatic protein. So phospholipase A2 basically acts on the extracellular matrix, mostly responsible for the tissue damage. And this phospholipid also involves the muscle cell membrane, disrupts the membrane completely, and subsequently causes tissue injury and myonecrosis. The non-enzymatic protein is also the same. It induces myonecrosis by physically perturbing the plasma membrane. So basically it acts on the membrane, disrupts the membrane cell wall, and causes massive tissue damage. Also affects the muscle cell membrane and causes muscle damage. So phospholipase A2 also contribute to neurotoxin, but its major role is to do the tissue damage. So in recent days, when we see a patient, we are not only dealing neurotoxicity, the tissue damage is probably now the most important problem we are facing, where we do not have really any major treatment options. Sorry for the disturbing pictures. So the tissue damage could be of this category. This gentleman is bitten here by a cobra. This one is bitten by a green pit viper. This is a green pit viper bite. This is again a cobra bite. So it can cause extensive damage, and many of the cases you need surgical debridement, even amputation, and so on. So anti-snake venom is probably not enough to halt the tissue damage or to neutralize the deleterious effect of phospholipase A2. The third important component is the metalloproteinase, which is responsible for bleeding, for hemorrhage. And snakebite metalloproteinase are fairly large molecules, predominantly acts on the circulatory compartments, and these play a central role by basically loosening the connective tissue wall, increase the vascular permeability. It disrupts the blood vessel integrity, and the bleeding happens. The problem of metalloproteinase is it synergistically also acts with phospholipase to do the tissue damage, and it helps to quickly spread of antivenom because of the increase of vascular permeability. Mostly it happens by the viper bites, and particularly Russell's viper, green pit viper, and other vipers in Africa. We have the Echis group. So the bleeding can happen from anywhere. You can see this is a green pit viper bite. This is a large hematoma after a green pit viper bite. This is a Russell viper's bite. See the coagulopathy, conjunctival hemorrhage, and this is intracerebral hemorrhage, can happen both in Russell's viper and green pit viper. The 20 minutes whole blood clotting test is a very cheap and easy classical test, which we do in the tropics to separate the cobra crate bite from the viper bite. And you can see that the blood clotting factor is not work in case of viper. Fresh frozen plasma sometimes we use as a supportive care, and others. And there are a whole lot of other proteins. 70% of the proteins are actually phospholipase and metalloproteinase, but serine protease and other whole lot of prostaglandins, bradykinins, and other protein works, and they also contribute to the tissue damage and also the muscle damage. So apart from anti-snake venom, what do we have in hand, or what is there any drug in the pipeline that we can use? So one drug is ramelteon and agomelatonin. So these are melatonin receptor agonists. So melatonin receptor agonist could play a major role in the regeneration of neuromuscular junction. So the function of the neuromuscular junction can be reversed in vitro by agomelatonin and ramelteon. These are already licensed drug used in case of insomnia and depression. So a group in Italy, they have tried on mice and found quite promising effect. You can see the evoke junctional potential is surrogate to degeneration, and the muscle action potential is the regeneration, where both of the drugs are showing quite promising effect, especially in the neurotoxicity, reversing the neurotoxicity in crate. This is the most talked about drug, that is the verespladib, a phospholipase A2 inhibitor. Originally, the drug was developed to treat acute coronary syndrome, but it didn't work. Developed by the Lilly Pharmaceuticals, then they took it off, and then some scientists in US, they have tried it in snakebite to halt the tissue damage. So recently, just this year, the phase 2 results have came out from India and USA. And you can see that the primary outcome is not that promising. It favors the placebo, although in the secondary outcome, the snakebite severity score have shown some benefit of using verespladib in case of cobra bites and viper bites. So we are waiting for the trial is also continuing, the Bravo trial, and we are waiting for the phase 3 trial result. The next drug in the pipeline is snake venom metalloproteinase inhibitor for the coagulopathy or vasculopathy. That's the marimestat. Marimestat is developed by a Polish company, and also the dimercaprol, the heavy metal chelating agent. Both can inhibit metalloproteinase in vitro. So the preclinical studies are showing some sort of benefits, especially with the marimestat. You can see the IC50 level is quite low for the marimestat, but they are promising drugs which needs to take into the patient for a phase 2 randomized trial. And the last drug I'm going to tell about is the serine protease. This is the nafamostat. This is also preclinical studies are telling some sort of benefit in mouse model, but we don't know what will be the dose and response in humans. So this also another promising drug which needs to bring into the phase 2 phase. So I would like to thank Professor James for inviting me here, and also Michael for always mentoring, and my Bangladeshi colleague from Toxicology Society of Bangladesh, Professor Aniruddha and Dr. Abdullah. We have established a venom research center in Bangladesh, in Chittagong, where we have more than 400 live snakes. So we are rearing them. It is one of the largest herpetarium in the South Asia. And we are trying to do some good research on snakebite in future. And of course, I would like to thank British Pharmacological Society for sponsoring me to having here. Thank you very much.
Again, absolutely super talk. Please do come down if you have any questions. While people think of questions, Ravi, could you tell us a bit about the availability of antivenoms in Bangladesh? Are they widely available?
No, not really. So this is a big issue in Bangladesh, and I'm sure in many countries, because not many companies develop or produce antivenom. So we have to rely on WHO funds and other funding, and we often run out of our stock. But we try to get prepared, especially before the rainy season when the cases will happen, but it is always a problem. And another issue is in the primary healthcare settings, the physicians sometimes get scared of giving anti-snake venom because of anaphylaxis. So in 15% cases, anaphylaxis can happen. So even though some sub-district hospital have antivenom, they refer the cases, and en route to referral, some patients died. So yeah, both is a problem.
Thank you. Please go ahead.
Thank you for the interesting talk. My name is Dheeraj. I'm one of the clinical pharmacologists here. I did my training in India, and some of the thoughts that you share I still echo with them. I had one question. There was some recent evidence which came around last year about heparin neutralizing cobra venom, and that's shown some benefit with the tissue damage and the amputations as well. Has that changed anything in your practice?
No, it's same in there is a preclinical study has shown that the heparin might get benefit in cobra, and some anecdotal case reports and series published from India that they have seen some benefit, but not much evidence yet. Yeah.
Thank you.
My name is Blessing Irihan. I'm a senior lecturer in pharmacology from Nottingham Trent University. Thank you very much for the very interesting talk. I'm quite intrigued at the level of work. So I was quite interested, when you talked about rearing about 400 live snakes. So, I would want you to throw a bit more light on probably laboratory safety and how how you're able to do that.
Yeah.
Thank you.
Thank you. That's a very good question. So it's a government-funded project, and the primary objective was to develop our own venom. The venom we use now is polyvalent antivenom, where the big 4 snake group is been covered, but ideally we should give monovalent antivenom. So it's a enthusiastic project of the government to make our own antivenom, especially for the Russell Viper and cobras. We take help from University of Frankfurt and also WHO. So WHO set up a lab there, and their experts also visit quite regularly for quality control issues and venom collection issues. We do give venom also to WHO for time to time for testing, and government is now trying to negotiate with a few companies in India and other places, at least to develop our own monovalent antivenom. In our lab, we are working on developing Russell's Viper monovalent antivenom, so we are doing the preclinical studies now in place. So it's quite, what should I say? It's It's an enthusiast or over-ambitious project for Bangladesh, but we are trying to manage it. And government is quite committed because it's very neglected and the problem of the poor. Yes, please.
Just one more question. Please go ahead.
Hi, thank you for the really interesting talk. My name is Rhea Shah. I'm a clinical pharmacology trainee here. I was wondering, there's a difference between the species of snake that did the biting. How often are you kind of informed of the actual species, or is this quite a big problem in terms of differentiating?
That's a very good practical question. So we use toxidrome-based approach. We have crate, cobra, and Russell's viper, green pit viper. So the toxidrome-based approach on an easy note is a bite without any local tissue damage, neurotoxicity, this is crate. A bite with local tissue damage and neurotoxicity, this is cobra. Local tissue damage plus coagulopathy, renal damage, this is Russell's viper. Local tissue damage with no renal manifestation, only the bleeding and prolonged prothrombin time, hematuria, hematochezia, that is green pit viper. That's a very common toxidrome we used, and actually this is quite effective, and most of the cases we got correct. Another advantage is, since we are using polyvalent antivenom, which covers crate, cobra, and Russell's viper also, if you can spot it as a venomous bite, giving the polyvalent antivenom helps.
Okay. Thank you very much, Ravi. That was a wonderful talk.
Thank you.
Thank you very much. So next we have Dr. Rebecca MacDonald. Rebecca is from the European Union Drugs Agency and is going to talk about the big challenge of opioid toxicity. Rebecca.
Thank you very much, James. I contributed to the NIHR Rights Center before joining the European Union Drugs Agency in January, and I'm here in a personal capacity, meaning that the views expressed in this presentation do not necessarily represent those of the European Commission or those of the agency. In terms of declarations of interest, I would just like to express my gratitude due to the British Pharmacological Society for the travel bursary, which allows me to be here with you today. If you followed the news in recent weeks, you may have seen a news article covering 3 deaths that occurred in London within 10 days in November, linked to a new synthetic opioid called cyclorphene, which is considered to be around 100 times stronger than heroin. And this is considered to be linked to a crackdown on precursors of, for nitazines. If you're from south of the border, you may also remember the outbreak of nitazines in November 2023 in Dublin, which was linked to 57 overdoses within just days in Dublin City, and you can see the HSE drug warning on the right side of the slide, as well as the billboards that were put up. Here's the one from St. Stephen's Green to alert the public of the extreme risk related to opioids and the need to carry naloxone. At global scale, since 2010, we've seen a roughly 45% increase in deaths related to drug use disorders, mainly from overdoses, and the WHO estimates that there is approximately 200,000 overdose deaths per year, predominantly from opioids. The US continue, despite a minor decline in deaths, to continue to account for the majority of deaths. Around 80,000 overdose deaths were counted in the US in 2024. But also we're seeing parallel epidemics of non-medical use of tramadol in North Africa, West Africa, the Near and Middle East, and Southwest Asia, which cause concern. In terms of response to this rise in opioid overdose deaths, the WHO published guidelines in 2014 stating that people likely to witness an opioid overdose should have access to the antidote naloxone and be instructed in its use to allow them to use it on the scene when an emergency occurs. So this is pre-hospital care. So when we refer to community-based naloxone, we mean the provision of a naloxone kit or taken naloxone, as well as training and its administration. In response to these guidelines, the US FDA then developed their own criteria for the development of non-injectable naloxone. So these new devices should enable non-professionals, so laypersons, to administer naloxone without risking needle stick injuries, and they should be so easy to use that they wouldn't need the supervision of healthcare professionals. In terms of pharmacokinetics, the guidelines are stated that these new formulations, such as nasal sprays, should give adequate systematic naloxone levels similar to the injectable reference, and also, given the emergency of the overdose, rapid onset of action compared to, again, the injectable forms. And these were tested in phase 1 trials in healthy volunteers, seeing that, of course, due to the risk of adverse events, they couldn't be tested in people with opioid use dependence. So here's just a slide, the PK data from one of these trials that led to the approval of a nasal spray. And what you can see is in purple, the intramuscular reference, and on the very left of the curve, you can see the IV spike. So these are the curves that we're trying to mimic with the nasal spray, and 3 formulations were tested, a 1 milligram dose, 2 milligram dose, and 4 milligram dose. And what was really decisive was to what extent, I need to go forward. The blood concentrations were similar in the first 10 to 15 minutes. The 1 milligram dose did not provide adequate dose availability in the bloods, whereas the 2 milligram dose did, as did the 4 milligrams, but with higher doses, of course, the risk of adverse event also increases. So this is sort of the balance that needs to be struck with these new formulations, but we now have nasal sprays in Europe for 2 milligrams or 1.8, as well as a slightly lower concentration, and in the US also higher dose nasal sprays with 4 milligram and 8 milligram dosage. However, these products come at a higher cost. And so when we think of scaling up overdose response in low-middle income countries, this needs to be considered because we're competing with ampules that can be purchased at a cost as little as £1 per dose. If you work in the NHS, you may be familiar with the pre-existing standard, which was the pre-filled syringe, which comes at a cost of £18, and the nasal spray is currently priced at 26. So if you think of £1 ampules, this is a lot of ampules, meaning that the feasibility of these newer nasal sprays for low-middle income countries at present is unfortunately limited. As an example, in terms of how overdose response can be scaled up, the WHO, together with the UNODC, the United Nations Office on Drugs and Crime, implemented a study between 2016 and 2021 in Central Asia, so Kazakhstan, Kyrgyzstan, Tajikistan, and Ukraine. And these 4 countries were chosen based on their high prevalence of injecting drug use, mostly heroin at the time, as well as limited treatment access. And in terms of the scale of the intervention, it was quite large. So over 14,000 people were trained in the use of naloxone, and in total 34,000 ampules of naloxone were given out. And what was really striking in terms of the cost of the intervention was that the kit, which you can see at the bottom right, was designed together with local NGOs, so service users who advised on what they would be willing to carry and what they would know how to use. And basically, this little kit contains 2 ampules as well as a clean syringe, and the cost due to bulk purchasing was as low as $1 per kit. And the estimated results, based on an extrapolation based on a cohort study and a subsample of the participants, showed that overall, over 4,000 people administered naloxone, and an estimated 398 lives were saved with this intervention. So these are this gives you, just in terms of putting it into perspective, roughly 400 lives saved as a result of 34,000 ampules distributed. Now, how do we estimate the need for naloxone in low middle income countries? You may be familiar with the Scottish National Naloxone Programme, which was based on the assumption that at least 20 times as many take-home naloxone kits should be given out as opioid-related deaths per year, or at least 9 times as many. This was based on sort of the heroin use in Scotland in the early 2010s. But of course, this requires reliable drug mortality data, which oftentimes in low middle income countries we do not have due to low autopsy rates and low toxicology testing capacity. And also, changing opioid use trends due to prescription opioids and fentanyls, for instance, need to be taken into account, the probability of naloxone use, as well as the number of deaths due to overdose averted. And of course, naloxone is only part of the range of interventions that we can offer. In fact, it's the very last one, the emergency intervention, whereas opioid availability of treatment and other interventions needs to be taken into account. And here, low middle-income countries are particularly vulnerable to funding cuts due to donor dependence. And just to illustrate this example, I'd like to quickly highlight a report from Harm Reduction International, which was published this year, highlighting the impact of the US executive orders earlier this year, which in February led to a stop work decision and the end of 40 US aid projects in South Africa, leading to closures in metropolitan areas covering key populations. So as an example, in 2 cities, the opioid agonist treatment and needle exchange sites serving 5,000 clients were shut. And immediately, due to the lack of prescribed opioids, clients were reporting shifting to street opioids, including suspected fentanyl exposures. The immediate harm observed was that overdose were reported within weeks of the closures. So here's an example of how the closure of services, the lack of availability, or the disruption of treatment services leads to higher risk of HIV transmission, hepatitis C transmission, overdoses, and deaths. So with that in mind, in terms of conclusion, with opioid overdose, we're fortunate in that we have medical intervention available at low cost, and establishing community naloxone procurement distribution is an urgent intervention with high mortality reduction potential, as the WHO UNODC data shows. In terms of wish list, we need, taking into consideration the more recent developments globally in terms of opioid supply and changes in use, we need better surveillance. Currently, overdose events are not captured in national systems. Peer reports of witnessed overdoses can fill in some gaps, but do not allow for national totals or public health programming. We need better responses, need for capacity building and coordinated responses, and this can include poisoning information centers, which Karine will be reporting on after my presentation. And finally, of course, there is need for funding also at national level and the inclusion of harm reduction strategies, including treatment and naloxone response in national drug strategies, with the allocation of dedicated funding to make countries less dependent on external donors and enable them to procure essential medicines such as naloxone, but also the treatment medications methadone and buprenorphine. And that's it from me. I'd like to thank James for inviting me and also Michael for his leadership on the center. Thank you very much.
I think we have time for a couple of questions while people are thinking. Rebecca, do you think it matters whether the naloxone's delivered by what route? Or do you feel that nasal is the best route? What route should countries use? Does it matter?
I don't think so. I think naloxone is naloxone is naloxone. I mean, with IV, you obviously get the immediate uptake, and intranasal can never be as good as intravenous. But in the community setting, it will be more accessible, oftentimes also because there's policy limitations to the availability of ampules. So many countries do not allow for the provision of injectable medicines by laypersons. So therefore, the non-injectables in some legislative settings are the best available tool that we can provide, but where there is workarounds in terms of policy ampules can be provided, and injectables, IV or IM, are probably preferable in terms of their cost.
Thank you.
Thank you.
Please go ahead.
Hi, thanks. Ian, one of the clinical pharmacology registrars from Glasgow. I'm interested in the more potent opioids and things like the nasal administrators. Are they sufficient in dosing? We often need to give patients multiple doses of naloxone just to get them stable. If we are talking about these drugs being much more widely available in the community, do we need to be offering more than one injector pen? Or where do we need to go with that?
Yeah, thank you. It's a really good question. Of course, very on the ball at the moment with the rise of synthetic opioids. There isn't enough data from hospitals. However, there was one, I sort of anticipate your question, study from New York State where law enforcement officials, police, are provided with take-home naloxone, well, with naloxone kits, nasal kits. And in the US, you have 2 sprays available, the 4 milligram one and the 8 milligram one. And this was published by the CDC in 2024. And basically, the survival rates were the same for either formulation. However, with the 8 milligram spray, which of course is the very top end, the rate of adverse events was higher, so people tended to vomit more. But yeah, in terms of efficacy, they were equal. Thank you.
Let's have one more question.
Hi, my name is Dheeraj. I'm one of the clinical pharmacology registrars. In Cardiff, we have the center called Vedinos, which runs a program looking at all the contaminants within the street drug market. And I think of late we've seen some of the morphine analogs of opiates which are being spiked into the heroin market. And interestingly, the researchers from Kent have done some preclinical work, and it's scary to see that naloxone is not seeming to be working in that because of the high binding affinity. We don't have much data around it. Is that something which you've come across in Europe as well?
Yes, we are monitoring the orphines and are trying to establish, or well, already have an existing early warning system where we're trying to capture better data on responses and the emergence of novel synthetic opioids, and keenly trying to keep an eye on the orphan situation. So yes, thank you. Unfortunately, we don't have a good response. Yeah, thank you.
Go on, Michael. I'll let you.
So really...
Go on.
Really slowly now. So there are 2 quite nice case series now looking at nitazines and naloxone responses. So in Australia, confirmed nitazine exposures from the US and from Australia, and both of them responded well to small doses of naloxone. So while it looks like naloxone shouldn't work for nitazines, it looks like at the moment they are doing. The best data we have is that they do work. So we don't need huge 10, 12 milligrams of naloxone for nitazines. Just 8.8 and 1.2 is working, it looks like, when we've confirmed it. So it's a theoretical problem which we haven't quite found if it's true yet, but it could be true.
Thank you so much, Michael.
Rebecca, thank you very much.
Thank
It was a
you.
wonderful talk. And for our final talk, and I'm pleased to say we're bang on time, I'm delighted to have Karine Marks come and join us from South Africa. Karine is the director of the Tygerberg Poison Centre in South Africa, and is going to finish off by talking about poison centres in Africa. Please, go ahead.
Good afternoon, everyone. So I'm Karine from the Division of Clinical Pharmacology, Stellenbosch University in South Africa, and my talk's going to be on poison information centres in Africa and the future of poison centres. So the WHO published on poisoning as a major public health concern, specifically if we look at snake bites in low and middle income countries, as well as pesticides. So for those of you who don't know what is a poison information centre, at the minimum we provide information and advice. We're an establishment, a unit, different from a poison centre. A poison centre has got a clinical treatment unit and often a laboratory, but a poison information centre, as shown there, if you work in a poison centre, you're known as a specialist in poison information or a spy. You get your call from the inquirer, who could be the public, but most likely a healthcare professional. He'll phone you, you use your own knowledge because you've trained, but you also have access to databases. For example, ToxBase, which is the UK database. In Africa, we use often AfriTox, specifically for South Africa poisons. So that's just a snapshot of what we take in our poison center in South Africa. So this is over a 6-month period, but altogether we take about 13,000 calls annually. It mostly concerns pharmaceuticals, so almost 50% of our calls involve pharmaceuticals, followed by pesticides, household products, animal bites and sting, and then handyman products. So again, for those of you who don't know, so what do we do in a poison center? Mainly poisoning advice, running a 24/7 helpline, but we also play a role in antidote surveillance, maintain databases, keep it up to date, education, research, poison prevention activities, community interaction. We play a role in international public health, data collection, toxicovigilance. So this is a map from the World Health Organization. Those red dots represent poison information centers. And as you can see, there's a lot of poison information centers in high-income countries. But if you look at Africa, there's only a few poison information centers. This study was done by the WHO African Regional Office over 3 months. And it asked poison centers, it was a survey about their data. 8 poison centers on the African continent responded to this survey. And as you can see in South Africa, take the most calls, followed by Algeria. And then there's some, a poison center, for example, in Madagascar, only took 9 calls over 6 months. So just a reminder where we find the low middle income countries, mostly on the African continent. So the area in red there, that's sub-Saharan Africa, where we find some of the poorest countries in the world, for example, Sudan, Mozambique. And we've got many developmental and economical problems, poverty, political instability, and just basic access to healthcare. So poisoning is a major concern, and there's limited access to healthcare. Poisoning often occurs in rural areas, snakebite, pesticide poisoning, and people don't have a health clinic close by. If they do get to hospitals, there's very often insufficient beds. The doctor that's seeing them got no medical training in toxicology. And then there's a limited availability of medication and antidotes. Furthermore, we have limited or poor quality data. There's small studies, poisoning is underreported, and as mentioned, there's only a few poison centers. And then we have unique toxicities to the continent. For example, snake bites, pesticide poisoning, and plant and medicinal poisonings, traditional medicine. So what are we doing? What are we currently doing on the continent? So through the NIHR project, we do Poison Information Center capacity building through online training, through face-to-face training, providing database, and giving mentorship. So our online training, we started the monthly medical toxicology network of Sub-Saharan Africa online meeting. It's once a month. It's open to anyone, so it's mostly medical toxicologists from Africa, but we also have international toxicologists joining, giving us their expertise. The role of them is to provide guidance to our colleagues from the African continent, where we deal with something like methanol poisoning, pesticide poisoning, snakebite. And then we also have a bi-monthly NIHR APMT Minotox webinar, where we have 2 speakers. One speaker will present on a clinical case and the other one on a poison information center. Education. So in 2021, Stellenbosch University was the first university that launched the postgraduate Diploma in Medical Toxicology. It's an online hybrid course over 18 months. It consists of 8 modules. There's only one face-to-face week, and that's in the second year when they come to the campus in Cape Town to write exams and to get experience. So also through the NIHR Right For, they give scholarships for this diploma, and currently they've given scholarships to 21 candidates from mostly Africa, but we also have candidates from other low middle income countries like India and the Philippines. This is some pictures of our students during the contact week. So apart from writing exams, they also have fun. They have a live spider workshop, and they handle live venomous snakes. Furthermore, through the NIHR, we have face-to-face training at international conferences. The first, normally in the beginning of the year, there's the Middle East and Northern Africa Conference, and then towards the end of the year is the Asia Pacific Association Conference. We provide databases to low middle income countries, to countries in Africa, free of charge, the ToxBase database. And through the NIHR, we also developed MyPit, which is a patient information database where you can capture information about the case that you're dealing with over the phone. It's just harmonized poison data, and every person using it owns their own data. Then we also provide SOPs on how to run a poison center and an annual data report template. Then we give mentorship at our poison center in South Africa. We train colleagues who wish to start a poison center. We have trained through the years many colleagues from the African continent. There in the top right corner, you can see our colleagues from Mozambique. And here in the bottom, that's our colleagues from Nigeria. They came to our poison center in 2023 for 2 weeks. And it is nice to report that they started the first poison information center in Nigeria. Michael and I had the opportunity to visit them last year in the poison center. So how do we know what toxicology needs a country have? So we need to rely on data. And as I mentioned to you, data on poisoning is very scarce, quantitative data. So we rely on qualitative data through this project via the NIHR, which is Work Project 4, Work Project 5. Here we're looking at the healthcare, the medical toxicology needs of healthcare workers. The aim and objectives of this project is to look at poisoning incidents, to look at gaps in medical toxicology in education, and the availability and affordability of antidotes. So this project is over 3 phases. We involved 4 African countries, Botswana, Nigeria, Zambia, and South Africa. So although we only can do 4 countries, the model can be used for any other country in Africa and also other lower middle income countries. Phase 1 is an online survey. That's followed then by in-person interviews and observation study in the hospital. So we concentrate on a tertiary hospital in each of these countries. Currently, we've already finished data collection in Nigeria and in Zambia. So we've had 28 semi-structured interviews completed, which we're busy analyzing, and 61% of those were doctors. So that's all the time I have. So what about the future of poison centers in Africa? That is to expand the 24/7 poison information service across Africa. And this is what the NIHR are doing since the initiation of this project. 2 new poison centers started in Africa, one in Zambia, one in Nigeria. Strengthen training, mentorship, and capacity building for healthcare workers. We're doing this via online meetings and a postgraduate diploma. To develop harmonized data systems for poisoning surveillance. We've done that. We developed the MyPit database. It's freely available. And lastly, we foster collaboration between countries, organizations, and communities. So I just want to thank James and the British Pharmaceutical Society for having me here today.
Fantastic, thank you, Karine. Any questions on poison centres?
It's very interesting topic, and I'm wondering if this kind of initiative and offering medical education and this talk space can be extended beyond Africa. For example, in my country, in Syria, we lack this, we lack all this, we don't have access, even not a lot of specialists in toxicology. There is a poison center, very, very like small. I went there, it's just like one room, not like actually like a poison center. And I think it really needs help in this area. So I don't know if it can be extended.
We would love to.
Yeah. So how can like contact?
You could speak to me afterwards, and then, yeah.
Thank you.
Hi, my name is Habon and I am a student at Queen Mary, so forgive me for my lack of knowledge. I have two questions. The first one regarding the future of poison information centres in more remote or rural areas or areas that are not really stable due to conflicts or just lack of medical supports. What would this look like in the next maybe 5 to 10 years? For example, in areas like East Africa or the Horn of Africa, where medical support or even just educational awareness of different poisonings are available.
It's a challenge. That's one of the reasons why we're doing the studies, especially in Eastern Africa, Western Africa. Luckily, poison centers can be run virtually. Now with new technology, we'll be able to countries to help each other. And in the future, I can see having a hub, poison information center hub, and many poison centers joining that virtual hub.
Okay, thank you. And for my second question is regarding unaccounted cases of poisoning. So again, like for areas that don't really have toxicology reports or just information regarding that, how can we improve our data collection and our understanding of different types of poisonings in certain regions so then we can better support dependent on the region's need?
Education. That's one of our main things in our postgraduate diploma, because it's a hybrid online course. We've got many candidates from Africa. For example, a colleague just now from Sudan, he graduated right now. And and then also we have the database that the NIHR developed. They can use it on their phones. It's very simple, user-friendly, and just capture the basic information when every poisoning occurs, and that way we collect data.
Thank you very much.
Great. Well, thank you very much, Karine. That wraps us up. I think it was a wonderful session. We're bang on time, and thank you to the speakers. I think you can all get away for lunch.